Well, thank you very much for inviting me to give this lecture and contribute to the session. I did not really go just into the imaging perspective, but hopefully we can have a great discussion here. So talking about late-breaking trials in mitral transcatheter, I thought everyone thinks about artificial intelligence. So I'm talking with ChatGPT and I say, tell me, what are the late-breaking trials? 22 and 23. Unfortunately, I got a very formal apology saying that as an AI language model, my knowledge predates that information, and I'm only going back to September 21. So I did not get any help as a disclosure from ChatGPT. However, I thought maybe I should ask what a late-breaking trial is, so we have a good definition. And here you see it. These are trials that are late-breaking because they come out after the scientific program for conference is complete, and then they break at the time of the conference. And they showcase groundbreaking research that has emerged too recently to be included in the program or publication of a meeting. Anyhow, with that knowledge, I think we cannot have a session like this and a talk like this without talking about the CORUP trial and the late-breaking recent results that came out at the time of the ACC meeting this year. And what this entails is a follow-up, if you will, 5 years out from the CORUP trial. And on the right-hand side, I added an image from my own repertoire looking at a central first clip in a functional MR type case. So that's the patient population we're talking about, secondary MR. Thinking back about the original CORUP trial, as you know, this was a very selected group of patients that were basically split in two groups. One was goal-directed medical therapy only. The other one was goal-directed medical therapy plus device, in this case, the mitral clip. And as we recall, after 2 years, there were groundbreaking results, which was a huge discrepancy in favor of clip plus therapy, favoring both on mortality as well as hospitalization for these types of patients. The yellow line indicates the crossover. After 2 years, patients in the goal-directed medical therapy could also cross over and get the device, and a subpopulation got the device, essentially then mimicking the green curve of the successfully treated patients with the mitral clip. So if we go from that to the 5-year result, again, here is the split of the groups. This was a multi-center, randomized, parallel controlled, and open label study. If you add the control group with the crossover, you see it on the right-hand side. After 2 years, there were 62 patients that were able to cross over and be treated with the clip. Now, looking at the whole time frame of 5 years, we do see that the curves for, here in this case, for mortality of any cause, continue to be staying away from each other. However, if you look at it with the glass half empty type of approach, you could say at 5 years, 57% of those treated with the clip device are essentially dead from any cause. So there's still a pretty large proportion of patients that are ultimately dying in the 5-year time frame. Now, there's a few other things to summarize. First of all, that we continue to see a lower rate of hospitalization and lower mortality at 5 years in favor of the treated patients. However, if you look at the whole population, 73% of the patients in the device group and 91 of those in the control group either died or were hospitalized for heart failure within 5 years. So it is a tough patient population despite the selection. I think it's really important for us as imagers to also understand the limitations of this trial, which includes the fact that the device treatment was unblinded and withdrawals favored the control group. It's also important to think about newer technology. And if you think about NTR, XTR, as we just saw in the cases that were discussed, as well as the generation 4 devices with the XTW and NTW, this may be more effective to reduce the MR to less than mild or down to less than mild and moderate. And outcomes with other mitral TEER devices such as Pascal from Edwards and non-TEER systems can also be potentially more favorable compared to what we saw in CORAPT. Goal-directed therapy is also improving. We have to acknowledge that. And if you carefully look at the patients in the CORAPT trial, only very few saw the favorable treatment with SGLT2 inhibitors, and then also only a subpopulation of less than 1/3 was actually treated with angiotensin receptor neprilysin inhibitors as well. And whether correction of MR would safely improve outcomes in more or less critically ill patients or those with moderate MR is also unknown. I wanted to add this image from an imager point of view, or this contribution that came out in 22. This is Joao Calvante from Minneapolis, who did some great work with the CORAPT investigators and basically staged patients into 4 different stages. And you can see these staging criteria relate to the left atrium, the significance of the left ventricular dysfunction, as well as pulmonary hypertension, and then also involvement of the right heart. And when you take this patient population that was included in CORAPT, you can separate them out in these 4 groups. And what you see across the board is that there is significant impact as the stages increase, that the hospitalizations and mortality goes up. Suffice it to say that it might be really important for us to look at additional echocardiographic parameters when we select patients and stratify for risk. I'm going to move on to a trial where we saw a lot of interesting results, both the EXPAND trial looking at mitral regurgitation as a primary MR as well as secondary MR. Again, this is 3rd generation mitral clips, and this was published in 23 in JACC, and as you see it here, a large group of authors that contributed to 1-year results of about 1,000+ patients. Again, this study includes the NTR and XTR clips. There's no wide clips included here yet. I added an additional reference where Mark Riesemann and myself actually summarized in a more dedicated piece the advantages of the potential of a longer clip as opposed to shorter clips for certain pathology, and how to best assign the clips as tools to the pathology based on anatomy that you derive from echocardiography. Here are the results from this 23 publication. More importantly, on the mitral MR, when it is primary on the left-hand side, you see a huge advantage of using a longer clip to perhaps reduce the height of the leaflets much more significantly and therefore impact MR more significantly compared to the original trials such as the Everest trial or the TVT registry focusing on primary MR. On the right-hand side, you see the results for secondary MR, and I don't think that there's much of a difference seen here in the secondary MR. And we see in our own patient population, we predominantly use the NT clips, mostly NTW clips nowadays, as opposed to the longer clips in the functional or secondary MR. Now, taking this to the next level for secondary MR focus only, again, for the Global EXPAND post-market study, this publication from Germany, also published in 23, highlights, again, the impact of the larger clip, especially on the functional MR, is not all that significant, and you see the utilization of XTR only versus NTR only is not quite as high. Again, it's important to look at the pathology, treat the pathology appropriately, and find out which clip is appropriate for which pathology. Finally, it's important for us to realize that this in 22 was also an important publication looking at a randomized comparison, now comparing a new TEER device, the Pascal, compared to the mitral clip. Again, once you have a landmark trial like COAPT, you have to compare yourself with a new device to what is considered at that point state-of-the-art. And this trial really shed some light on that and ensured us and convinced us that the Pascal device is non-inferior when you look at all kinds of endpoints, making it a great option in the patient who is prohibitively at risk for surgery with symptomatic degenerative MR. And here you see the results and the impact more or less indistinguishable between the two devices. Again, important information to take along when you're considering which devices to use. To look a little bit in the future, I'm really excited about these two ongoing trials that I brought along. They both can be easily found in clinicaltrials.gov. One is called the Repair MR study. What's important here is that the patients that are being included and randomized are only at moderate surgical risk. So for the first time, we're really going to see some results there. This also includes fourth generation, newer generation MitraClip technology, again, where you have 4 options of treatment depending on the pathology. The primary outcome is, again, all-cause mortality, stroke, cardiac hospitalization, including kidney injury. And then the other second ongoing clinical trial, where we don't have results yet, is also quite exciting. This is a prospective multi-center open-label randomized trial, now looking at any TEER device that's available, and that's a 1-to-1 ratio comparison in 450 patients now with primary degenerative MR. Again, the outcome is very similar for the primary outcome, all-cause mortality, valve reintervention, and hospitalizations, or onset of more than 3+ MR. I'm taking this last slide to bring it back to the imaging piece, and highly recommend, if you're interested, to look at this paper on the left that is the result of a collaboration between Enrique Garcia-Sayan, an imager, as well as myself, and basically between his Texan institution and the University of Washington, where we looked at about 150 patients of our initial MitraClip outcomes with the Generation 4 devices. And what resulted out of that work is the schematic on the right-hand side, which actually you can get for free now in its current iteration in the ebook, which I'm highlighting at the bottom. That is a SCAI ebook. All you have to do is register for the SCAI. You don't even have to be a paying member, and you can download this ebook for free. And what we tried here is to really make a suggestion for optimized utilization of this toolkit, depending on the anatomy, the pathology that you find in your patient, the absence of calcium, the length of the leaflets, the leaflet height, and things of that nature that may inform you which clip to use, either long or short, wide or more narrow, and what the predominant use is. As you see on the left-hand side, this image down there at the bottom, in the secondary FMR patients, we predominantly use the NTW clip, and in a lesser number of cases use the long clip, as I mentioned before. With that, I would like to just highlight a little bit of a future perspective. The impact of the newest generations of TEER devices on long-term outcomes remain to be seen. I believe goal-directed medical therapy, even though it has its limits, it's still evolving as well, and perhaps not as well represented at its best in some of these trials for which we see long-term outcomes now. And then therapeutic approaches should include right heart assessment and then also potentially right heart intervention, including tricuspid TEER. That may further improve overall outcomes. And then I cannot overstretch the importance of patient identification, and for us to think about risk stratification. Again, the burden is on us as imagers to look at that as an important goal. And with that, I thank you for your attention.